Autoimmune diseases are quite difficult to manage, and you should not ever rely on steroid therapy for long-term use. Steroid therapies are only used to suppress an acute attack. So, most of the time, for some patients, of course, steroid therapy can help them avoid a surgical intervention, but eventually, so many of our patients will need a surgical intervention. But you need to understand the different natures of ulcerative colitis and Crohn's disease to understand what kind of surgery is useful for both of them, because they're quite different in their approach. This question is about ulcerative colitis. And as you can see, this ulcerative colitis is about colon. So the colon and the entire colon will be affected by the disease. Maybe the inflammation will be apparent in one part of the disease at the beginning, but eventually it will involve the entire colon. And if you remove a part of it, the other part will become manifesting and disease later on. So any surgical intervention to relieve a patient of ulcerative colitis condition should include removal of the entire colon. Okay, this is the first question. So this patient has a long history of ulcerative colitis. If you have a long history of ulcerative colitis, there is an increased risk of complications and especially of developing colorectal cancer, especially if it's more than 10 years and if you have a pancolitis. So, as I mentioned, you cannot continue giving the patient steroids. We have to stop steroids at some point. But if we try to stop them and our trial fails, there is no other way to do it. We cannot keep the patient on steroids, and we cannot keep the patient complaining of symptoms without steroids. So the surgery becomes the only option. But as I mentioned, we can only do it by removing the entire colon. So anything that doesn't say removal of the entire colon cannot be our choice. You cannot do a subtotal colectomy, and you cannot just remove the colon and rectum. This is not enough. And of course, you can remove the colon and rectum, but they're going to talk about it. This patient doesn't require a stoma. So anything that has a stoma in it should not be happening. Ileostomy, colostomy isn't going to give the patient the right treatment. You need to remove the entire colon to prevent any further manifestations of ulcerative colitis, and you do the ileoanal pouch for two reasons. First of all, as I mentioned, ulcerative colitis only affects the colon, so the ileum and the anal canal, the anus, both of them are disease-free. So if you make anastomosis between both of them, you don't have most of the time any risk of developing inflammation in them because they are immune most of the time to the inflammatory responses of ulcerative colitis. So there's no need to do a perineal excision. This is a rather extensive surgery. We do it only for colorectal cancer patients. But a panproctocolectomy, removal of procto means rectum, and colectomy is the colon, ectomy means removal, and construction of the ileoanal pouch because the patient wants to avoid a permanent stoma. Okay? So the most fundamental difference between the ulcerative colitis and Crohn's disease is you can surgically cure a patient of ulcerative colitis by just removing the entire colon. Of course, you'll have manifestations of no colon, which is a lot of diarrhea and electrolyte loss and fluid loss, but he can have no disease. Crohn's disease, on the other side, is not restricted to any particular part of the bowel. It can manifest with oral ulcers, esophageal ulcers, gastric ulcers, duodenal ulcers, jejunal ulcers, ileal ulcers, and colon ulcers, and anal ulcers. So no surgical intervention can cure a patient of Crohn's disease. So most of the time we rely heavily on immunosuppressive drugs to maintain a tolerable lifestyle for the patients. So this is the fundamental difference in the surgical approach. If you think about the patients with Crohn's disease and you're going to do surgery for them, it's usually a surgery to avoid some particular mechanical problems. Example would be like a patient with a stenosis. Crohn's disease is known to produce stenoses, and if you have a stenosis, patient will have constipation, obstruction, and obstruction is its complications. So what we do is that, and we try to do it as limited as we can because we cannot just keep giving the patients resections and anastomosis, because this will lead to short bowel syndrome. So what we do is we try to do that only if the conservative treatment fails us, so we have to do it only rarely. And to do that, we need to make sure that when we do anastomosis, we make sure that we just don't fuse the end to end because this will lead to stenosis. We try to make it obliquely so that the surface area is larger and the risk of stenosis is reduced. The other thing is that Crohn's disease is also known for producing fistulas because it's transmural, it invades deeply, it penetrates, it's a very aggressive. It can make a fistula between the skin outside and the gut on the inside, and this requires treatment. But remember, if you have a patient with Crohn's disease fistula, surgery won't be the only solution because these patients will have recurrence of fistulation. So again, this patient had long term of ulcerative colitis. Steroids couldn't be stopped. Surgery was the only option. You can only remove the entire colon of ulcerative colitis, and the patient wanted to avoid a stoma, so no longer need for ileostomy won't be suitable for the patient. Colostomy won't be suitable. This is an extensive surgery. We cannot do it for a patient with ulcerative colitis. This is our chosen one. This is a subtotal colectomy. You will remove a part of the you will remove a big part of the colon, but you will keep some, and this some will have inflammations later on. Thank you.